Let's move on to the gluteal approach to the sciatic nerve. These are categorized into transgluteal, subgluteal, and infragluteal. According to the New Delphi consensus, any approach that involves piercing the gluteal muscle is classified as transgluteal approach. Techniques performed below that muscular layer are considered as infragluteal approach. So, a total of 4 main approaches to the sciatic nerve are currently recognized: parasacral approach, transgluteal approach, infragluteal approach, and anterior sciatic approach. Let's understand the transgluteal approach. The Labatt's approach is landmark guided technique described before the PNS era. The landmarks used are posterior superior iliac spine and greater trochanter. A line is drawn connecting these two landmarks. Then a second line is drawn perpendicular to the first from its midpoint. The needle entry point is marked as 4 cm caudal along the perpendicular line. The Winnie's approach is a modification of Labatt's technique. In this approach, an additional line is drawn connecting the greater trochanter and sacral hiatus. A perpendicular line is dropped from the midpoint of posterior superior iliac spine and greater trochanter line. The needle entry point is at the intersection of this perpendicular line with the GT and sacral hiatus line. Both Labatt's and Winnie's approaches have become less commonly used in modern practice due to the depth of the sciatic nerve at this level and difficulty in visualizing it under ultrasound. Some articles do describe transgluteal ultrasound-guided approach where the probe is placed directly over the needle entry point of the Labatt's and Winnie's techniques. In this location, the sciatic nerve appears sandwiched between gluteus maximus muscle above and superior gemellus below. Two important vascular landmarks are often seen: inferior gluteal artery lying medial to the sciatic nerve and pudendal artery seen above the ischium and medially. The needle is inserted lateral to the medial direction, avoiding these vessels, and local anesthetic is deposited in the plane between the epimysium of gluteus maximus and superior gemellus, targeting the sciatic nerve. For subgluteal approach, the key landmarks are greater trochanter and ischial tuberosity. A line is drawn connecting these two bony points. Therefore, this approach is commonly referred to as GT and IT approach. For PNS guidance, the needle is inserted at the midpoint of the GT-IT line. This technique can be performed with the patient in either prone or lateral position. It can be done in supine with the leg in lithotomy position. In that case, it is called as Raj supine approach. To perform the ultrasound-guided subgluteal approach, we must understand the anatomy of subgluteal space. This space lies under the gluteus maximus muscle just above the junction of the thigh and the gluteal region. The bed of the sciatic nerve here is formed by the quadratus femoris muscle. If you look into the gap beneath the gluteal region, the subgluteal space is defined by the superior boundary by the epimysium of the gluteus maximus, inferior boundary formed by the epimysium of the quadratus femoris. Medially it is bounded by the ischial tuberosity and laterally it is bounded by the greater trochanter. In simple terms, this is a potential space between two muscles and two bones. Within this space, you can see the origin of the hamstrings from the ischial tuberosity. Along with the sciatic nerve, you can also find posterior cutaneous nerve of the thigh lying very close to the sciatic nerve. Now to both the heads of the biceps femoris, now to quadratus femoris. Inferior gluteal nerve often accompanied by the pulsating inferior gluteal artery, vasa nervosum of the sciatic nerve, and the medial circumflex femoral artery seen at the lateral edge. In ultrasound-guided GT-IT or subgluteal approach, the probe is placed at the midpoint of GT-IT line. The sciatic nerve appears in short axis as a hyperechoic oval or round structure. It is visualized between the epimysiums of the gluteus maximus above and quadratus femoris below. The sciatic nerve is typically seen more medially closer to the ischial tuberosity than laterally. In this approach, posterior cutaneous nerve of the thigh can be blocked complementarily, covering the skin over the posterior thigh. Additionally, it can also involve the motor branches to the hamstring muscle due to presence of those in the same space.
approach or the subgluteal approach. Some people might take a landmark like 4 centimeter below this midpoint. Both are described in the literature and elicit the response, the tibial or the common peroneal component. And once you get that it is not intraneural, less than 0.2, it is not coming, you can aspirate and deposit the drug. Please pay attention to this video, ultrasound guided video. There is a loss of ecotexture between the nerve and the surrounding muscles because it was an old patient. So you will get similar kind of pictures when you are dealing with the old patient. It is not as good as that schematic. So here nothing is visible. That's why we need to scan in cephalad and caudal direction, that is scout scanning, as well as a nerve stimulator to stimulate and identify. So here you can see that was the anterior injection. So now I'm changing the needle again and trying to go in the subgluteal space. Now this injection is again outside the subgluteal space. Now I'm in the subgluteal space in the right plane, and with the injection, as you can see, the beautiful spread of the drug which is pushing the nerve. In the subgluteal space, on ultrasound, you will see the nerve is more towards the ischial tuberosity, rather exactly in the midpoint between the two. So post-block scanning, you can scan in cephalocaudal direction, or you can scan in the longitudinal direction also, so that it will give you an idea about the correct deposition. As I told.
In the Franco approach, the gluteal cleft is identified, a line is drawn from the midpoint of the cleft extending laterally. A needle entry point is marked at 10 cm on this line. This corresponds to the midpoint of GT and IT. The ultrasound probe can be placed at this point to obtain the similar image at GT and IT or subgluteal approach. To summarize, all transgluteal approaches involve piercing the gluteus maximus. Posterior cutaneous nerve of the thigh can often be blocked incidentally. Due to high vascularity, color Doppler is useful to identify and avoid vessels. Nerve to hamstrings may also be anesthetized depending on the location. The infragluteal approach is also known as Sukhani's approach. Here, the inferior gluteal crease is marked with the patient in prone or lateral position. Upon asking the patient to flex the ipsilateral knee against the resistance, a dimple-like depression appears just below the crease. Within this depression, the tendon of bicep femoris can be palpated, and the sciatic nerve lies just lateral to this tendon, and this is the most superficial location of the sciatic nerve. At this site, the sciatic nerve is not covered by any muscle. Only skin and subcutaneous tissue lie above it. Due to its superficial location, sciatic nerve can sometimes be compressed during prolonged sitting, leading to slip foot. The needle entry point is usually 1 to 2 cm lateral to the bicep tendon, just below the gluteal crease in the region of palpable depression. At this level, the bed of the sciatic nerve is formed by the adductor minimus muscle, as described before. Upon placing the ultrasound probe at this location, the sciatic nerve can be seen between the hypoechoic hamstring muscles above and typically bicep femoris medially and semitendinosus laterally, and the adductor minimus muscle below. In this region, vascularity is very low, the nerve is very superficial, and anatomy is easily accessible under ultrasound. Local anesthetic is deposited into the intermuscular plane, targeting the subparaneural compartment. The effect of this block is similar to that of popliteal sciatic nerve block, hence it is also referred to as highest popliteal sciatic block.